Welcome back. So now the committee members and I are going to discuss what we've learned throughout the day from the various presentations and Q&A sessions. We still have more presenters and a panel discussion tomorrow, but I want us to reflect on what we heard today. After we conclude this series in September, we will submit a report to the Secretary of Health and Human Services on population-based total cost of care models. Our reflections at these meetings will help shape our findings in that report. So for committee members, I'm going to ask you to find the potential topics for deliberation document. It's in the left front pocket of your binder. To indicate that you have a comment, again, just please flip your name placard. So we're now going to open it up for comments for the committee members. The potential topics are listed on the slide, but you can also see those in your handout. So I'll turn it over to the committee for comments. Larry.
So we heard models described in fully employed situations. We heard about primary care models. We heard about how specialists interact with the primary care models. To me, there was a single best practice. If we're talking about best practices, there's a single best practice theme that permeated just about everything, and that's high-touch, proactive patient engagement. And to me, that's almost a must. After listening to everybody today, we have to be proactive. We have to have a lot of touches. Whether it's a primary care doctor or a specialty care doctor doing it, I don't know that environment is different. So, I mean, that's I think one of my biggest takeaways from today.
Lee?
Yeah, really rich discussion today. I think I was just reflecting on some of the themes we've heard, and some of Angela's recent comments, I think, really highlight that. One is just the importance of thinking and recasting primary care. It just has to be done differently, and that includes resourcing that is real, but it's not as hugely overwhelming as it sometimes is feared to be. It can be fairly modest. Focused resourcing makes all the difference in the world inside a different model. That model pairs with some compensation changes. Again, you can't keep doing the same thing and expecting different results. I think all of us have lived through that. The centrality of data that has to be polysourced, has to be bigger than any one practice, one doctor, one EMR, frankly, even one system or one payer. So I think Dr. Kendrick spoke powerfully to those challenges and opportunities. And then lastly, to pick up what Larry just pointed on, we heard, sometimes I oversimplify, say it's just doing the job, but it's just the high touch, get where the patient is and find out what they need. And that's not rocket surgery, but it is something that doesn't happen in the traditional model of medical practice. And that's the secret sauce to everything we've heard about today.
Yeah, thanks. I mean, I'll add to that, particularly on the data. I thought Dr. Kendricks, I mean, that was really, I know the data that I work with, and I think it's okay. I know it's not great, but when I saw that map of the country and Oklahoma and where all the patients are getting their care, I mean, that's really powerful to realize that, how, we tend to be very centered on our either health system or community or state. So the data piece, which is really challenging but so important, is certainly one of the takeaways I was thinking about. And the other thought again around these high touches, which I think you brought up, was around the culture change that's needed. I can tell you in my organization, I have, quite a few primary care doctors who sort of want help, but then they want to control. And so I'm sure, Angela, in your model, I'm sure you come across that. And it is a culture. So any of these things require culture change to move to a new model and how best to do that.
I'll just build on that. I think some really interesting themes that I've seen in my work and also in partnership with other sites is really the concept of case finding. So utilizing data to find people with needs, or really a longitudinal relationship where you're looking in your population for people with needs before they have them. And then another theme I thought was really interesting and teased out is the cultural change and the kind of training. So Angela talked about this, but it was true across the other models as well. It's very different to do a longitudinal relationship and build that sort of full knowledge, comprehensive across settings in EMR. What is that patient's story and how does it integrate? That's different kind of work and culture than proactively light touch reaching out in that 70% of rising risk. Different people like to do those things, and the training's different, but they're both necessary to get total cost of care. And then I think tomorrow we'll have an opportunity to go even deeper on some of the social determinant of health investments and opportunities, and also the populations that aren't intersecting with primary care. So what's happening with them, because they're also in that total cost of care equation. But we did hear some great themes about reaching out to where the people are and the importance of transportation as well with social determinants. So lots of rich dialogue.
One of the point I'd like to make is that either we have to make it easier to migrate to global risk and or create a lot more waivers that are easy to get, because we have our hands tied frequently because of our inability to do things because of regulatory issues. If we get past those waivers, it'll make things a lot easier. So identifying those and addressing those, I think, is useful.
I think what struck me most, and this has come out in a number of these sessions that we've done, is that the care delivery itself at the patient level may be a simple intervention, but the incentives and payment programs around it are extremely complicated. And I appreciated hearing these disruptions and innovations. But back to a couple of other themes. There's still a disproportionate amount of employed physician practice where the biggest innovations are happening, which may or may not be replicatable. This big data strategy is one that absolutely works. But again, the question around feasibility is one that I think I appreciated the comment that, again, if I'm remembering correctly, but there's 25 nodes across the U.S. That potentially could be linked, which I think is really an opportunity for CMMI to be thinking about how do we incent leverage of that data. And then I was also struck by multiple examples of how to get care teams to want to participate, either with a carrot or a bulking at a disincentive. And so we heard a number of 30 to 50% of total comp at risk for performance, and and there was all kinds of micro examples at the clinical staff person or provider level, absent contracting, because we heard a lot of, I thought, interesting ideas around contracting about how to make this work. And I'm also struck by the fact that a health system strategy for which I work is unlikely to be the right model, and these private-public partnerships are the ones that appear to be the most successful.
Yeah, so just following up on that comment on incentives, I believe Kaiser Lore has it that one of the co-founders of Kaiser, Sidney Garfield, physician, was found nails down in a construction site to prevent infection from a tetanus wound from these construction workers he was seeing in clinic. And similarly, we heard Dr. Khan today talk about a really vivid example of going out to, it sounded like a trailer park, looking for a woman with a diabetic foot ulcer in a Celica, along with a social worker, by the way, so the care team, to prevent or treat a diabetic foot infection. What he didn't say, which I assume is implied, is that he was doing that to prevent downstream worsening of infection, potential hospitalization with weeks of IV antibiotics, post-acute care, preventing a $15,000 to $30,000 stay in the inpatient and subacute areas of healthcare. And he was doing that with a simple physician visit along with the social worker. And so I think, as I'm thinking about total cost of care, how this committee can help maybe think about a payment system that incents that kind of really profoundly innovative primary care. How do we create the right incentives to substitute low cost, high value care for much higher cost care downstream? And I think we had some great examples of that today. And I think we'll have some more tomorrow too, as I look forward to tomorrow's subject matter experts.
I go?
Other comments?
Yeah, I have one. It's Bruce. As I keep telling you, I've been around a long time. And the notion of doing more, and as a result of doing more, spending less, has been around for a long time, but it's kind of when you want to have an actuary in your hip pocket to come out and say, oh yeah, well, what's the evidence of that? And I guess I'm thinking of, in particular, the presentations by Drs. Zimmerman and Kendrick, who have now a decent-looking time series where it does appear that the upfront patient engagement approach yields downstream less spending. I'm going to give them the benefit of the doubt that their methods are up to snuff, but that cynicism about doing more and spending less has got to be still there somewhere. I'm not sure I've done away with it myself.
Thanks, Bruce. Josh?
Yeah, I think lots of things to chew on and reflect on today. And I think setting aside the data piece others have, I think, articulated really well, and putting aside high-level actuarial considerations for the moment, I think, I at least quickly kind of found 7 things that I'm taking away from today. And the through line for this is to be thinking about how, to me, under certain arrangements like Medicare Advantage, people either said or indirectly implied that they don't have to worry about certain things. So I'm cognizant that there are certain activities, delivery activities, where they can do it and not have to mind those things. And I'm thinking, how, if possible, can we translate to a world where people do have to mind those things? And there may be some trade-offs there, but how do we do that? So the first was around kind of removing barriers. Angela talked about the services that can create the financial proposition for it, taking away patient copays. I think he also mentioned waivers as that kind of bridge. That's maybe not the end state, but that is one way we can think about operationalizing that. The other is to think about maximizing opportunities, so reframing downside as actually the ability to take upside. And I think it's fair to say that as we think about TCOC models, one of the limitations I think historically has been there hasn't been a lot of upside there. And that ratcheting effect of benchmarks just further dampens that. So just a very concrete design thing is, if we don't expand that some way, I don't think we can get that analog to what Angelo's talking about. The team-based approach and the kind of touches, but maybe not coming from each team member, kind of distributing the work among team members is a good idea. Again, under certain models or approaches, you don't need to count those. I think in some fee-for-service arrangements you do. And so I think thinking about how we define eligible professionals for different services, and how we think about access. So for example, in the forthcoming REACH model, there is that element around expanded MP access. So to be determined, but there are, I think, practical things we can do to begin fitting different activities to different people in an incremental way. I really was struck by something Angela said and Dana Safran said around quality, which is that often I think we incentivize clinicians and physicians in particular to work on utilization. It's not surprising to me. And then seeing, Larry's response about if you engage clinicians in quality, it motivates them. Someone's got to mind the utilization, but it doesn't have to be them. And, Dana had that element in AQC where they just pay people on quality, like no matter how you did, on the spending. And so, how do we think about that? The models that I'm aware of in the more restrictive fee-for-service world tend to gate on quality, but they don't reward on quality. So I think there's probably a revisiting there that can happen to get closer to those things. I'll buzz through the last couple quickly. I think we heard from Dr. Zimmerman about maturity, and I think we say glide path a lot. I don't know that our models have had the glide paths that we can see, and I think it's doable in my mind. So I'd love to see more of that. Sherry Erickson talked about what is a high value referral, and there are a lot of bullets there. And I think what I took away from that was you do have to mind the details in some ways. And so some of the codes and the services we're talking about here do have those details, and they can be frustrating, but they also help ensure that's not just like, I coordinated care and that was good. And so I think we'll have to kind of grapple with how specific we want certain things to be. And then finally, what I took away from the kidney model presentation was that there are these other non-primary care realms in which these things can be applied. I do think issues of accountability and culture need to be addressed. But I'm hoping that some of the learnings from this we can use as a way where I think it's fit to task in primary care often, not so much in others, but I'm hoping we can move in that direction. So in each of these, I do think there are little things we can do, but in the spirit of trying to say, how do we capture the spirit of all the things we heard today, but also acknowledge like the reason they're so gripping is because they can be done in a world where there's more flexibility. So.
Yeah, I appreciate all those comments. Just picking up on the quality one, I was, looking at one of the topics around addressing unintended consequences. Always think about that whenever we're thinking about total cost of care. And, to the point that if, focusing on quality, because you always worry on the other side, could you be stinting on care? And so you need to counterbalance measures to be sure. And that's really hard to do, to be honest with you. And so, when having the physicians or clinicians focused on utilization can sometimes exacerbate some of those unintended consequences around potential stinting of care, where if you really have them focused on quality and quality measures and outcomes, one, it's an area they feel, passionate about and very comfortable, obviously. And also, I think enhances that relationship with the patient, because it's all about the quality of care that you're trying to get to.
Yeah, and I can just say in follow-up, I think many of us are clinicians, and a lot of us think about financial incentives. And one thing also came up about giving trophies, which I don't get many of from Dr. Zimmerman, but that idea of like what motivates people is not all money. I mean, that is one thing, but it's not everything. And speaking as a general internist and having many colleagues in primary care, I think people do things and they spend the time and they work in the EHR because it's the right thing, not because they're thinking about that bonus. And so I think the alternate is not like nothing. There's harms, there's like errors of tying too much, I think, to utilization. It creates these potentially twisted incentives that we don't want. So.
Yeah, and I was also thinking about, and I'm sorry, I forgot which presentation we talked about risk adjustment, the problems around our current way of doing risk adjustment, which really focuses often on cost, but not necessarily on needs. And I thought that resonated in my thinking as well. As we always think about that as an issue about our current risk adjustment methodology, but where does that need to move so that it really does, think about the patient? Yeah.
Yeah, I agree. I think what I heard in that same comment, we focused a lot on risk adjustment and how to get credit for taking care of complicated patients. But I think what our speaker said today was think about payment adjustments for taking care of complicated patients, right, rather than trying to create a homogeneous benchmark, essentially. And I think that's a really interesting way to create incentives to actually want to focus on that patient population. That said, the other comment I'll make is I do wonder, currently many of the models or the innovative care delivery programs that we've heard about, from a total cost of care perspective, the winners have disproportionately focused on high cost utilizers, which is no surprise, but it assumes a couple of things. One, that the mean will never get better, right? So that you can always beat a rate by just focusing on those patients. And even in the renal care model, it really doesn't incent what we have, what's been described as probably being value added, and that's back into that preventative care space. And so the question is, is that a sustainable model, only focusing on, and in that renal care model, it was broken up into fourths, where basically the patients who had accelerated all the way to the end of transplant, nothing you can do about it. But in that sort of progression of disease space, there was the most opportunity, and we're definitely hearing a theme of these groups who, right, that's where the biggest revenue generation is. Right. And so it's creating potentially disparities in focusing on these high cost patients.
Yeah. Yes, fine.
It's also assuming that the high-cost patient of last year is going to be the high-cost patient of next year and the year after, and that is a flawed assumption.
Yeah.
And the opposite of that, the low one's going to be low cost going forward too.
Yeah. Other thoughts, comments? Bruce, anything else? No? You're okay? Okay. Okay. So I want to thank everyone for participating today, our expert presenters, my PTAC colleagues, and those listening in. We certainly have more to cover, as we alluded to, related to care delivery for population-based total cost of care models. So we'll be back tomorrow morning at 9:30 a.m. Eastern. Liz Fowler, the CMS Deputy Administrator and Director of the CMS Innovation Center, will deliver opening remarks. So we hope to see you all then. Thank you. This meeting is adjourned for the day.
Produced by the U.S. Department of Health and Human Services.